Hello, everyone. I'm Lillian Kell, President of Ifso, and I have the pleasure of moderating this webinar today. This is our third of our series of webinars on COVID-19, and I'd like to thank Johnson & Johnson for sponsoring this webinar. I would also like to extend a warm welcome to all of you who have logged on to attend this webinar on what has been a challenging and unprecedented pandemic. Who would have thought that a viral outbreak in the wet markets of Wuhan in December would have led to a pandemic in 210 countries around the world? And today there are 3.1 million confirmed cases and more than 218 deaths globally. In the past several weeks, we have adapted to working in new ways, and our physical workplaces have changed. Elective surgery have been banned in many countries. We communicate differently. We're transforming the way we develop solutions. And for the most part, this new norm is becoming normalized. As you know, we have not been able to meet face to face. So we are here to share our thoughts and experiences digitally. In addition, the way we operate in our operating theaters have also changed. In this era of minimally invasive surgery, we were advised early in the pandemic outbreak that perhaps we should be performing laparotomies to minimize the spread of the virus. How can it be so? So today we will discuss about the risks of laparoscopy versus laparotomy in a COVID-19 patient and look at what is the evidence. So please join me in welcoming our esteemed faculty who have taken their time to talk to us today. Firstly, I would like to introduce Dr. Ahmad Bashir, who is the chair of the Ifso community from Jordan. Welcome, Ahmad.
Thank you.
I've also got Dr. Diego Camacho from the New York City in USA, who's going to talk about laparoscopy versus laparotomy. Last but not least, we have Dr. Syed Safari from Iran to talk to us about his experiences in Tehran. So dear attendees, please sit back, be comfortable, be ready for a stimulating hour of discussions. At the end of the presentations, there will be opportunities for questions. So do send in your questions, your comments, so that our presenters can answer them. And I'll do my best to get through as many of the questions as time permits. Before we start our presentation, I'd just like to do a poll for all the attendees. And the first quick poll is pertaining to guidelines. What are you or your institution implementing within your practice or your healthcare system? So please select one or more of the following: hospital-made required changes, triage, visitor policy, etc. Testing all patients prior to any intervention, no elective procedures, full PPEs to staff regardless of risk, or limited laparoscopy and favor laparotomy. So do your poll and submit it, please. Okay, are we done with this poll? All right, so 62% if you have said that hospital-made required changes, 59% have got no elective procedures, 43% are testing all patients prior to any intervention, and 30% full PPEs, 30% full laparoscopy without laparotomy. Okay, thank you for your poll. So I'm going to invite our first speaker, Dr. Ahmad Bashir, to talk about comparative analysis on recent guidelines on COVID-19. Thank you, Ahmad.
Thank you, Dr. Cal, and thank you, Ifso, for the opportunity to present. I'm going to be comparing and analyzing the recent COVID-19 guidelines. I have nothing to disclose. This is my practice breakdown as required per the communication committee. And while reviewing the guidelines, I saw a statement by Winston Churchill, which I thought that was very relevant to what we're living through right now. When the situation was manageable, it was neglected. And now that it is thoroughly out of hand, we apply too late the remedies, which then might have affected a cure. Want of foresight, unwillingness to act when action would be simple and effective, lack of clear thinking, confusion of counsel until the emergency comes, until self-preservation strikes its jarring gong. These are the features which constitute the endless repetition of history. And he made that in 1935. And this is why we need guidelines. We all know guidelines are equivalent to policies and procedures. And the guidelines that have been made for COVID-19 are placed for prevention and treatment. And the three areas that I'm going to cover: patients, facilities, and workers. We know how guidelines are built by reviewing best evidence, making recommendations, disseminating those recommendations, implementing them, and evaluating them. And the outcomes are fed back into the best evidence loop. And initially, the guidelines do not take into account any barriers, shortages of staff, equipment, or absence of any requirement. And for those in the audience who are geared toward treatment guidelines, I recommend that you review the recent NIH guidelines published in April 24th on their website. And they go through the details of every step of the way of taking care of a COVID-19 patient. However, in their summary, they do not recommend any pre-exposure prophylaxis agent or post-exposure, and no drugs that are found to be effective right now. Another that is a good resource is in Critical Care Medicine Journal, Surviving Sepsis. It's a meta-analysis of all the best evidence that we have in taking care of patients in ICU. And the guidelines I reviewed are the WHO, CDC, NIH, NICE, several surgical societies, and the best published evidence out there. So we all know patients present with the common symptoms, but from a surgeon standpoint, always remember that diarrhea, nausea, and vomiting can be presenting symptoms. And new loss of taste or smell, I'm pretty sure Dr. Safari will talk about that. The altered level of consciousness and signs of ARDS are poor prognostic signs. Lymphopenia, high procalcitonin, which is not normally seen, and a sign of bacterial superinfection, as well as high D-dimer and altered coagulation, are all signs of poor prognostic factors. And the specific testing, chest X-ray and the more sensitive chest CT, and for diagnostic purposes, all guidelines recommend the use of PCR, and the main two sources and nasopharyngeal and oropharyngeal swabs. However, they're not the most sensitive. And if you look at the sensitivities, bronchoalveolar lavage is the most sensitive, and sputum is more actually sensitive than the nasal or pharyngeal swabs. Serological testing to detect IgM and IgG, such as in the rapid test or the ELISA, the rapid test, can help us in emergency situations. It gives you the result within 10 to 30 minutes to detect IgG and IgM antibodies. But the NIH warns that a negative test does not exclude a COVID infection, as we do not know when these antibodies form. And a positive test does not mean that it's positive. Depending on the kit that you're using, the sensitivities and specificities are anywhere between 90 and 99%. And with a 99% sensitivity and specificity, you have a 16.1% false positive rate due to cross-reactivity with other viruses. That's why the FDA is taking its time to validate all the commercial kits, and they only approved 2 so far. As far as admission guidelines, NICE were the first to release their admission guidelines, and they incorporated the frailty score into their guidelines, and they got publicly scrutinized for making those recommendations. However, they entertained the idea that 6 or more may not receive critical care. And those who are not familiar with the frailty score, the higher the score is, the more dependent you are on others for needs. But as we gathered more data and we knew the risk factors, age above 65, and now the CDC is releasing weekly the main medical problems that pose risk on hospitalization. And we know now that hypertension is the most, second followed by obesity, and third, diabetes. And these are being incorporated into newer admission guidelines, like the one released by Pirelli and colleagues. And they also identified them in risk factors for critical care as well, with other scores like the REM score, Rapid Emergency Medicine Score, incorporating age, heart rate, respiratory rate, mean arterial pressure, and Glasgow Coma Scale with O2 saturation. REM score predicts mortality, and it predicts it better in the younger age population. So if you have a REM score of 6 or higher, there's a higher chance of mortality. What do we do with asymptomatic patients? And the best advice by all guidelines is to test all patients if testing is possible and available, and take full precautions by facility and workers, and do not consider a negative test as an exclusion for COVID infection. And for those who did not attend last week's webinar, the joint with AIS, we went through a lot of recommendations and guidelines. Professor Ross and Dr. Nameri went through the facility guidelines in details, the tier response, Dr. Abadaya for the endoscopy, and Dr. Wadwa and Manzoni for anesthesia. And I recommend watching those, as I will not go through these guidelines. But what I can tell you that the WHO and the CDC detailed what the facilities should do. First, a designated triage area prior to entry to the facility, and manage the patient and visitor flow within the facility, taking into account all standard precautions to apply. And make sure that you have enough PPE training, and monitor your staff on PPE use, and increase environmental cleaning and disinfection with proper waste management. And the WHO specifically stressed the ventilation aspect in the general world to be 60 liters per second, as opposed to 120 liters per second in rooms where aerosol generating procedures are being undertaken, with the best practice being negative pressure rather than anything else. And monitor your staff for exposure, and establish a reporting routine within your facility and with the public health officials. And to make those changes, they're best made with engineering controls rather than administrating control and just implementing PPE use. And Wang and colleagues went through those changes in their institution, and I'm referencing them just because of the few changes that have been made engineering-wise. Of course, they made donning and doffing areas and signs to help workers and guide them. But the most interesting is pre-packaging of all the needs of any procedure, minor or major, within a specific package to help everybody get their equipment straight, not more, not less, as well as protecting their equipment in aerosol generating procedure rooms by simply covering them, and making sure that the staff is using the proper PPE. And we know now what the standard full and enhanced PPE, and the enhanced PPE should be used in established or highly suspected COVID patients, but at least a standard PPE in patients without symptoms. And when best practice cannot be implemented, this is where guidelines adapt. The WHO lists in detail what you should use bare minimum in every work area and every situation. And I recommend those who are taking care of facilities to look at those. However, with the decrease in implementation, that increases the exposure risk on workers. Thus, self-monitoring by staff and active monitoring by the facility and the administration has to be increased. And if exposure is confirmed, then you need to provide a detailed report back to public authorities provided by the WHO. And according to the level of the risk of contamination, possibly quarantine the workers for 14 days. However, the CDC in their March 7th release, they allowed asymptomatic workers to work with COVID infection due to shortages and lack of staff. And NIH detailed the reuse of disposable N95 masks. They went through several ways of decontaminating those masks. And the best was use of vaporized hydrogen peroxide, which decontaminates and kills the virus within 10 minutes. And you can reuse it up to 3 times with 2 decontaminations. However, they warn that the fit changes with each decontamination, and you should check that fit. And we've seen innovations outside guidelines by workers. This is a face shield by a paper file. And this is one worker reusing her N95 mask with a lunchbox, keeping it inside a lunchbox away from additional contamination. But we're here for surgery guidelines, and the Royal College of Surgeons were the first to release their surgery guidelines, and they advised canceling all elective cases, emergency or urgent cases, to test all patients, do CTs prior, make sure that your theater is well equipped with smoke extraction, and follow intubation and extubation guidelines in the theater. And for your planned procedures, make sure that you add the greater risk of surgery with COVID-19 and use risk-reducing strategies, preferring stoma creations as opposed to anastomoses. And they advised against laparoscopy and to minimize the use of energy devices and make sure that the PPE properly used, with endoscopy following suit the surgery guidelines. Later, SAGES relaxed a little bit on the laparoscopy guidelines as the risk was not defined in literature, but they still advised the use of smoke filters and minimizing the use of energy devices. And more societies came together to collaborate. This is the Theodore Billroth and many European societies coming together with their own guidelines, considering gasless laparoscopy and still emphasizing the use of stoma more than anastomoses. And I'm pretty sure Dr. Diego Camacho will go through it. The Spanish Association of Surgeons, however, recommending laparoscopy over laparotomy on April 4th, steering the debate of laparoscopy versus laparotomy. And they actually advised doing intracorporeal anastomoses and using the abdomen as a barrier to protect the staff inside the operating room with the use of filters. And they advised against stoma creation because stoma is another mode of transmission of the virus in the care of those patients. And that debate I'll leave to Dr. Camacho. What I'll add is all guidelines go against open wounds and open abdomen, and the disinfection is best by vaporized hydrogen peroxide. And the American College of Surgeons first triaged what to do as far as procedures are concerned. Elective and semi-elective, they should be postponed and canceled. However, high acuity procedures should not be postponed and they should carry along. The Royal College of Surgeons followed suit with their priority levels and that we are aware of. And they detailed the list of cancers that can be postponed and how long they can be postponed per stage, going through all types of cancers, GI and others. And the American College of Surgeons followed suit. And the lists are similar per stage, per cancer. And this review is very interesting. Mitura and colleagues actually reviewed all those guidelines and implemented them according to their needs. And in their institution, they did not treat COVID-19 patients in-house, but they developed the entire criteria of risk stratifications, facility tier response, and they took the important steps of designating an area for COVID-19 patients presenting with surgical emergency, and made sure that the flow of those patients does not cross path with other patients with dedicated OR zones, training the staff. And they developed their own guideline and implemented laparoscopy within those guidelines if laparoscopy carried benefit to the patient, regardless of the COVID status of the patient. But nowadays, we're starting to talk about restarting elective surgery and looking back at how do we restart. Remind you that Dr. Peng Zhang, in the first webinar of the COVID series, advised that you should think about restarting 2 weeks after the deceleration curve ends. And the American College of Surgeons went through the phases of what you should do. And the first phase is awareness and preparedness. The knowledge of COVID-19 status within your community. Are you able to test for COVID-19? Make sure that you have enough PPE supply, and check your facility capacity and the OR status and supply, and try to adapt the OR status for a potential increase in demand given all the cancellations that has happened in the backlog. And make sure you have enough workforce available, and develop a governance committee to plan and monitor all these steps. For patient issues, they advised a patient committee for reviewing all patients' needs and transparent communication. Review all the workup of those patients who were canceled and plan for additional workup if needed, and make sure you have a policy for testing of COVID-19 and a policy for a potential COVID-19 patient within those circumstances. And consider increasing the capacity if the demand is high, working on the weekends or overtime. And make sure you still deliver high quality care. Review your outcomes and make sure you monitor all phases. Preoperative phase with patients, they advised telemedicine for review and preparation. And immediately preoperatively, make sure you have a checklist to incorporate COVID-19 within your consent with the increased risk. And make sure intraoperatively you take all precautions with PPE and disinfection. And postoperatively, make sure you have a plan of discharge for COVID-19 patients and all the issues pertaining to that. It's a lot to go through, but to sum up, it's a trying phase with a lot of potential to learn and an added experience. Be flexible and adapt your guidelines to your own needs, but make sure to test all patients if possible and protect yourself and your staff. And we're all in this together. Maintain a sense of community, like Professor Ross mentioned last week, and continuously monitor, evaluate, communicate clearly, and share your outcomes. Thank you.
Thank you very much, Dr. Bashir, for such a succinct presentation. We will go through all the presentations and we'll leave the questions to the end. And again, I urge the attendees to send in your questions to me so that I can set up your questions to the end. Before we go to our second presentation, I'd like to do a second poll to the attendees. And this poll is, what do you think the standard of care will be for MIS until we have a vaccine against COVID-19? Select one or more of the following. Full PPEs for all OR team, testing all surgical patients prior to the surgery, prefer open surgery instead of laparoscopic or endoscopic, use of smoke filter evacuators for all cases, surgery only for patients who failed medical management. Please submit your poll. Okay, we should have some results fairly shortly. Okay, so majority of the 82% would like to test all surgical patients prior to surgery. 70% use of smoke filter evacuators in all cases, 67% full PPEs for all OR team, and not so many prefer open surgery or surgery only for patients who failed medical treatment. Thank you for that poll. I will now move on to our second presentation. Dr. Diego Camacho is going to talk about laparoscopy versus laparotomy risks in COVID-19 patients. Thank you, Diego.
Well, thank you very much. Good morning or good evening, wherever you are. Thank you for Ifso and the Educational Committee for this invitation. It's an honor to be here presenting with you guys. So today I'm going to talk about laparoscopy versus laparotomy in the times of COVID-19. First, I would like to disclose something. I'm not a virologist, I'm not an epidemiologist, and I'm just a surgeon trying to go back to normal life. Let's start talking about where we are today. These are numbers from yesterday. There are over 3 million patients infected around the world with the virus, a little bit over 200,000 deaths. The United States, as you can see, occupies the number one country with most cases, with a little bit more than 1 million patients infected, with close to 60,000 deaths. This is the distribution in the United States, different areas with different infection rates. But clearly, New York has become the epidemic or the epicenter of the disease, with at least almost 300 cases, 300,000 cases. As you can see in the in my graphic at the bottom, the Bronx, where it's where I practice, one of the bureaus of New York State, is probably the one that has the most infected patients. So I'm not going to spend too much time talking about the virus, but we need to understand who we're dealing with or who we are fighting against. It's RNA virus. His name came from the Latin word corona, that means crown. And you can see that it has little spikes in the surface, and that's why it's the name coronavirus. It was detected in December of 2019, and before that, there were only 6 other coronaviruses that were known to infect humans. The transmission rates definitely comes from animals and then to humans, and the coronavirus or COVID-19 is very easy. These are the 2 other subtypes that affected the world in 2002, 2003, and 2012. The SARS that had a mortality of almost 10%, and the Middle East respiratory syndrome with almost 37% mortality rate. So we know that the virus came from the wet labs of Wuhan in 2019, and compared to his subtype of SARS, it shared almost 80% genetic sequence similarities between the pandemic of 2002 and 2003. Not many studies have been done yet in this virus. We're still learning how it works, and a lot of things need to be answered. So planning surgery during COVID-19, I think that 6 weeks ago, this was a very easy answer for laparoscopic or open, as long as we were following the guidelines of surgery. But since March, where the large societies came with very strong recommendations based on a short series and publications, especially this one that came from China, from Wuhan, 34 patients that were evaluated during the incubation period that proved that the patients had high complication and mortality rates. They divided the patients in different groups depending on the severity of the surgery. But as you can see, out of the 34 patients, 7 patients died. So that shows a big mortality rate. All these patients, the 34, developed pneumonia in the post-op time. This is our unpublished data at Montefiore. We're still evaluating these patients, but as you can see, we have performed 51 surgeries between the mid-March until last week. I'm not talking about vascular cases here, abdominal surgeries, 22 with almost 50% complication rate and 2 deaths. Those 2 deaths were related to a solid organ transplant. Interesting that in the group of laparoscopy of cholecystectomy, mastectomies and appendectomies, there were no deaths. There were only 2 complications. One was related to an abscess in a post-appendectomy patient, but did not show any deaths in this group. In the device group, where we're talking about PEG tubes and tracheostomy tubes, 1 death was reported, and this is a chronic patient that was admitted to a hospital before the first reported cases and got infected during the time and died in the following days. As you can see, we have 9 out of the 51 patients, 9 were positive patients before patients went to the OR, and we had 5 patients that have a clinical suspicion, even though the studies and the tests were reported as negative, and we had 37 patients. So the complication rate was below 50%, and the mortality was in the 4 or 5% range, which is still very high. So looking at all this small case series and reports, the societies came very strong with some recommendations and suggestions on how to treat patients with COVID or in the times of COVID. And they suspended all elective surgeries, and they recommended that laparoscopic surgery might be helpful for all these patients, and they recommended to avoid surgery on those patients that did not have any emergent procedures. So as we were talking before, we're using guidelines, we're using algorithms, personal experiences, talking to other experts, and this is the one that we are currently using at Montefiore, and this was approved by our chairman. So currently we are not performing any elective surgeries, only emergencies. The cases have to be approved by the chairman before we go ahead with the procedure. But if we have a patient that presents to the emergency department with a surgical problem that surgery can be avoided, definitely we'll postpone the surgery. But what happens with those patients that require surgery and need some type of intervention? And this is where we come with this algorithm of, if patients are positive for COVID-19 and no respiratory problems and surgery is necessary, we obtain a rapid test in the emergency department or in the surgical wards. We try to obtain chest CTs or X-rays and spirometry to see and to evaluate the respiratory condition of these patients. We discuss with them the surgical consent of all the complications and potential risk of this virus. And if appropriate, we perform laparoscopy versus laparotomy. If the patient is positive 19 with severe respiratory problems, definitely we try to avoid at all costs or intervening on these patients. But if we have to do it and the patients have a respiratory support, we prefer to do open surgery in these cases. This has been only 1 patient that we perform an explanatory laparotomy. So the problem and the questions from the societies was like if there is any risk of transmission during the time of surgery. And this is why Dr. Fingerhut and Dr. Singh came with some recommendations, and they published 2 papers in regards to guidelines and taking care of these patients. We all know that during the surgery, we create smoke during the dissection, and there is a contamination or aerosolization with the viruses in these patients. There are clearly studies that have been shown that there is a presence of virus and transmission to humans during the surgery. This is one of them that we can prove that there is virus particles in the aerosol during this study, where hepatitis B was detected in 10 patients out of the 11 cases that underwent surgery. There are case reports and case series as well of patients developing throat cancer related to the HPV after the surgeons have been exposed to the smoke. But what about SARS-CoV-19? As of today, there is no study that has shown or proven that there is any transmission, but because it's similarity with his subtype in the SARS-CoV-1, and there was a study that there was transmission of this virus, we assume that there is a potential risk of the COVID-19 to be transmitted to humans during surgery. So as we mentioned before, we are listening to guidelines and trying to get expert opinions and recommendations from other institutions or our own personal experience. And we, after looking that definitely laparoscopy can benefit these patients tremendously, surgical societies became a little bit more flexible and recommending that laparoscopic surgery should be performed in the right patient using the right equipment. We all know that open surgery has some negative factors in this pandemic, and this could be related to prolonged hospital stay, increased use of intensive care unit, increased risk of patients that are negative that can be contaminated while they're in the hospital. We're trying to perform laparoscopic surgery, and the patients, if they meet criteria, can be discharged from the recovery rooms for most of the common procedures that are laparoscopic appendectomies and cholecystectomies. The recommendations from the European Endoscopic Association recommending that all patients should be tested in the emergency department or the medical or surgical wards to identify the status of the patients, if they're positive or negative. Definitely, we are treating all patients, regardless of the status, if they're positive or negative, if they're going to undergo surgery as positive patients. So we are mandating all OR staff and surgeons to use personal PPEs as mandated by the guidelines. Definitely using 95 mask is most, since we know that 95% of the filter can be stopped through these masks. So what are the benefits of laparoscopic versus open surgery? Clearly, we know that it's a contained space, and if the patients meet the criteria for the surgery and we follow what we know how to do, laparoscopic surgery with the insertion of the trocars, using trocars that do not have escape of smoke, these patients definitely can benefit from the surgery versus the open. We know that laparoscopic surgery is a contained space. It's a way that we can control the evacuation of the pneumoperitoneum, and we can control the pressure. We also can control the smoke and the aerosol inside the abdominal to avoid exposure of the smoke and the viruses once we perform the open surgery. So even though we're performing laparoscopic surgery, if we have to open, we can evacuate the abdominal cavity with the special filters to try to minimize or to lower the risk of contamination of the OR personnel. So these are recommendations from the European Society. As we were talking, we have to make sure that all the instrumentation should be maintained clean, even though we don't know if this virus can be transmitted through the blood. But all the instrumentation and the trocar should be maintained clean. Try not to mobilize the trocar as much. Make sure that there is no gas leak from the laparoscopic instruments. In regards to the pneumoperitoneum, we try to maintain the lowest amount of pressure in the abdominal cavity that it's safe to perform the surgery. Try to reduce the Trendelenburg position to irritate the diaphragm. Definitely, we need to have two valves on the trocars, one that we can insufflate through one of the trocars and one to evacuate through the other one. So evacuation of the smoke has to be done with HEPA filters or the anesthesia filters, because that way we can prevent the viruses to escape from the evacuation of the smoke. This article was published by the European Society and Dr. Fingerhut, and it's a small system. It's a simple system of connecting the trocar to an IV tubing and posteriorly connecting it to a anesthesia filter. Many other options have been sent to me. This is a group from Brazil that it's a closed system, that it's a seal-tight system that also uses the HEPA filter by Dr. Morel and Alexander Morel. This is another type of filter that they're using in India, where you can see that it's a simple insertion of the trocar with connecting to a HEPA filter. I'm not going to promote any specific ones, but this is the one that we're using. It's a connection to the machine. I don't know if you can hear, but this is how we do it. It's HEPA filter with two tubings, one that insufflates the pneumoperitoneum, and the other one extracts the smoke from the abdominal cavity. And when we are about to finish the case, this is one of my appendectomies, we lower very slow the pressure of the abdominal cavity one by one until we lower the pressure to almost zero. You can see that the purple tubing is the entrance, and the white tubing on the 12th port side is the one that we're using to extract the smoke from the abdominal cavity. So this is the one that we're currently using and has been having very good results. I'm not trying to promote any companies, but this is the one that we're using. It has been very effective, and you can see that it evacuates the smoke very fast. In regards to the electric energy, try to avoid high charges. We try to lower as much as we can to prevent the formation of the smoke. We need to have specific areas in the hospital where all COVID positive patients are going to go in the immediate post-op. If the patient is a positive patient, we like to keep them for at least 48 hours for observation, since we know that these patients have high chances of developing pneumonia in the immediate post-op care. And definitely it's the OR staff. We try to avoid personnel that do not need to be in the operating rooms. We try to avoid medical students, company reps, only the important staff that are gonna assist or help during the procedure. All of us try to use the PPEs as mandated by the hospital. We are treating, as I said, every patient like if they were positive. We are, even though we have some patients that are negative, we're still treating them like if they were positive. And very important, and we do not talk about this, the consent prior to surgery. We discuss with the patient the risk of being infected during the hospital stay, or the chances of them infecting the operating staff or the hospital staff. So it's very important that we have a separate consent on these patients as well. So in my conclusions, I will say that, as you can see, there most guidelines and recommendations come from experts. Try to avoid surgery if possible in patients who are positive COVID. Laparoscopic surgery, definitely, if indicated and the patient qualifies, has better benefits compared to open surgery. We have to evaluate case by case and try to avoid contamination with fluids from the patient. So thank you very much again. This was one surgery that we did 2 days ago on a patient who required a laparoscopic cholecystectomy on a negative COVID patient, but as you can tell, we're still using all the PPE protection. Thank you, and be safe in these difficult times.
Thank you, Diego. That was a very comprehensive presentation. Before we move on to our next presentation, I have another poll for the audience. And to the audience, thank you. I've seen some questions come in, so keep sending them in. This next poll, the question is, given concerns on infectivity of laparoscopic gas and the need to restart elective surgery, what's the ideal choice in your practice? Select one of the following. Wait for pandemic resolves, start my practice gradually. Wait until the peak passes, then start gradually. I have to start my practice with full precautions, only open surgery. I prefer to start my practice laparoscopy with full precaution. I will wait more with full precautions no matter whether it's lap or open. So put in your choice in the poll and let's see what the results are. Okay, the poll is closed. Let's see what the results are. So 50% of you would like to start your practice with laparoscopy and full precaution. The rest, you're not too sure. Okay, thanks for your responses. Let's move on to our third speaker. Our third speaker is Dr. Saad Safari from Iran. And he's going to share with us the bariatric surgical practice during the initial phase of COVID-19. For those of you who have just joined us, this webinar is being recorded and will be on the virtual academy in the Ifso website. And it will be available probably in the next 24 hours. All right. Thank you, Dr. Saad Safari.
Hello. You have my screen. Can you hear me? Hello. Can you hear me?
Yes, we can. Yes, we can see. We can see and your slides and hear you. Go ahead.
Okay. Good evening, everybody. I'm Dr. Safari. I'm from Iran, and this is our study that have been published around 10 days ago, published online in Obesity Surgery. You can see the names of my honorable colleagues here that shared their experience with us and helped us to publish this paper in a timely manner. What I'm presenting here is mainly based on this article. We conducted a request on a closed social media of Iranian Ifso surgeons. We have 62 Iranian Ifso surgeons, and we asked for any case of COVID-19 after a bariatric surgery, and we found that we have 4 post-bariatric COVID-19 cases. The mean age of these 4 patients was 46 years, and the mean BMI was 49. I have a timeline video here of the cases that I would like to share with you. Okay. This is the timeline, and I hope you can see it well. Case number 1 was a female 63-year-old that with BMI of 51 that underwent Roux-en-Y gastric bypass. Just 1 day later, she came with the symptoms of COVID-19 infection with fever, dyspnea, and passing out. And she was admitted. She had a positive chest CT scan. She had a positive COVID test. And she was admitted to the hospital for 11 days in ICU and general ward 2, and then discharged home. Excuse me, do you hear me well?
Yes, we hear you.
Yes.
Okay. Case number 2. It was a female 43-year-old with BMI 50. And she underwent gastric bypass Roux-en-Y 2, and she came to the hospital again after 14 days with symptoms of COVID-19, with fatigue, with other symptoms, and she had positive results on chest CT and also on COVID-19 test, and she was admitted to the hospital, 4 days ICU care with treatment of hydroxychloroquine, and then she discharged home. Case number 3 was again a female, 35 year old. And let me show you this. She underwent again a Roux-en-Y gastric bypass, and 4 days later she came to the hospital with fever, cough, dyspnea. You can see the chest CT here. She had a positive chest CT, had a positive COVID test, and she went to the ICU, 10 days hospital stay, and then discharged home. And case number 4. Case number 4 was a male that underwent single anastomosis gastric bypass. 2 days later, he had fever, cough, dyspnea, a positive chest CT scan. You can see the chest CT scan. And he was treated outpatiently for a couple of days, and eventually he survived. All these 4 cases survived, but we had diagnostic and therapeutic challenges in the post-operative period. And if you look at the cases number 1 and number 4, you can see that these patients may have the disease beforehand they came to the hospital for bariatric surgery. And case number 2 and number 3, they may have been infected in the hospital, so the hospital transmission may be really correct here. Okay, let me go to the next slide. In this article discussion, I would like to tell that we know that elective bariatric practice is banned in most highly affected areas in the world. But why? Because post-operative complication with COVID-19 may be a diagnostic challenge. Also, it is a therapeutic challenge too. If you have a dyspnea after a bariatric surgery, you have to think about leaks, you have to think about pulmonary emboli, you have to think about portosplenic mesenteric ischemia, and now you have to think about COVID-19 infection too. We know that morbid obesity may be a potential risk factor for severe cases, for very severe cases, and also it may favor for mortality. And also there is risk of transmission to the healthcare workers and then to the community. All we know about the surgical smoke, as Dr. Camacho touched it beautifully, is nothing, because we don't know about this novel virus. We know that HIV, HPV, and hepatitis B can be present in the surgical smoke, but about COVID-19, we don't have a documented study till now. Also, if we look at the surgeons and the personnel involving in these 4 surgical teams, they were around 30 persons, and nobody had a disease in more than 1 month's follow-up. So we don't know this risk is how much it is really. Also, we did a study in Iran here. This is not a published work. In four patients, two laparotomy and 2 other surgeries, and we checked many different tissues for involving by COVID-19 virus. We didn't find any intra-abdominal tissue involved by the coronavirus. We didn't find any adipose tissue involved by coronavirus. We didn't find any urine samples involved by coronavirus, but we had 3 out of 4 cases positive stools. In conclusion, I would like to say that we know that full precautions with full PPE, detailed history taking, prompt testing of the patients before any procedure if possible, these all are essential in diagnosing and controlling the disease. But if the surgery is needed, I prefer doing laparoscopy other than open surgery. Why? Because laparoscopy gives you less hospital stay, it gives you less need for post-op clinic visits, it gives you less exposure to the body tissues and fluids that we don't have confirmed data about their infectivity. about this concern that surgical smoke and laparoscopic gas may contain the virus. We don't have yet the conclusive data. Also, we know that only most experienced surgeons must have the surgeries if they are needed, with full PPE and also smoke filters, as Dr. Camacho told previously. Okay, at the end, as we are learning how to live with COVID-19, we have to learn how to operate with COVID-19 too. Thank you, everybody.
Thank you, Syed. Now, before we go to the questions, I have 2 more polls for the attendees. So the first one is, how will COVID-19 pandemic and concerns over the spread of the virus impact your usage of smoke evacuation in the future? Please select one of the following. I use smoke evacuation and will continue to use it in the future. I don't use smoke evacuation and won't use it in the future. I don't use smoke evacuation but will use in some cases. I don't use smoke evacuation but will use on all my cases. Please put in your choices. All right, let's see what the results are. Somewhat divided, but majority say don't use smoke evacuation, what will use on all my cases. 1/3 will use smoke evacuation and will continue to use it in the future. All right, one last quick poll, one last question. How has SARS-CoV-2 pandemic changed your use of electrosurgical devices in minimally invasive surgical procedures? Select one of the following. My habits with electrosurgical devices have not changed. I have minimized my use of monopolar in MIS procedures. I've minimized my use of bipolar in MIS procedures. I've minimized my use of ultrasonic in MIS procedures. So please vote now. Okay, let's see the results. So majority of you have stated that your habits with electrosurgical devices have not changed. Okay, that's good. All right, let's come to some questions then. I'm just looking at the questions that have come in. One of the questions that have come in is, what do you think about robotic bariatric surgery during the COVID-19? Who would like to answer that question?
Yeah, this is a big discussion. We had a webinar just recent. I think that there are some surgeons that are considering that doing robotic surgery is not going to affect in any way, as long as the patient, again, meets the criteria for laparoscopy robotic surgery. The question is that there's one of the concerns was that normally this surgery takes in the very experienced hands could take a short period, a short time, but in the regular, normal hands of a surgeon, I think that the surgeries can take a little bit longer. So that was one of the concerns. I think that as long as we follow all the guidelines of COVID-19, using the right PPEs, the evacuation, for now at least, because as I mentioned before, I think that this is a moving target. So whatever the guidelines are today might change tomorrow. but we're thinking that robotic surgery can be done or performed in a okay way. One of the concerns also was like the recycling of the instrumentation, because some of these instruments can be reused, and there was some concerns that if there is any way that we can transmit, if we have some type of interaction of the virus with the instruments, and we can transmit that way the virus. But those are just concerns that no one has been able to prove. But at the end, they said like robotic surgery potentially could be done in COVID patients, or in the time of COVID. Probably not if in the COVID patient, but in the pandemic of COVID.
Okay, another question is, how has the threshold for medical management of acute appendicitis changed during COVID-19?
You want me to answer that question as well?
Anyone can?
I will say that the number of emergency cases at our institution has decreased at least 80%. I mean, we are a very high volume of surgery in the Bronx. We are the largest medical center in the Bronx, and our surgical cases has decreased for at least 80%. We are dealing with appendicitis. At the beginning, we were sending them home on antibiotics and medical treatment. But if the patient now, with our experience, if the patient is a good candidate, it's a negative COVID, we'll do laparoscopic surgery on these patients. But it can be done both ways, medical management, if it's an early and uncomplicated, but if definitely there is a complicated appendicitis, we'll do the surgery laparoscopically.
Okay, I have another question. Your comments on using IgG and IgM testing prior to surgery or endoscopy?
Thank you, Dr. Cao. Guidelines are recommending using serological testing only for surveillance purposes so far. So rapid testing is being used for general surveillance, and guidelines recommend still using PCR and not relying on the rapid test to diagnose somebody with COVID. Now, they are being implemented in emergency situations just so somebody knows, but the idea is if you're going in a patient who you think has a high risk, you better be well equipped with enhanced PPE, regardless of surgery or endoscopy. If you have a low suspicion, at least standard PPE is recommended, either in surgery or endoscopy.
Okay. My next question is, it's not really true that laparoscopic surgery is contained. What about leakage of carbon dioxide via the ports and the instrument channels? This is coming out under pressure. Please comment.
So I think that this was addressed before in other webinars. I think that as long as we know and we try to use the standard of care of placing the ports, trying to manipulate the entrance of the instrumentation into the abdominal cavity, trying to make the appropriate size incisions for the trocars, I think that we can avoid in some way. There is no way that we can say that 100% we're not going to have some type of leakage of the smoke or the pneumoperitoneum, but we try to minimize that by following the guidelines and being very strict on placement of the ports, making sure that all the ports that we're going to use have valves that are working fine. At the time of surgery, the incision site plays a big role as well, and but there is no way that we can say that in 100% we're going to prevent any type of leakage of smoke into the atmosphere. No one can say that for sure. We can control the evacuation with this new system, but definitely 100% you're not gonna get.
And you know, Diego, if I can add, the risk is there even in open surgery. If you're using energy devices, the smoke is still there. You can still use smoke evacuators, but the idea of having the abdomen as a barrier is a theoretical, you know, idea. We have no proof, but it might add to the benefit if laparoscopy carries a high benefit to patients.
I think that it's a contained space, you know, it's a contained space that we can control the you know, creation of pneumoperitoneum and evacuation. I think that I create more smoke when I open the abdominal cavity with the bovie. I have seen that. I think that I create more smoke with the open surgery than laparoscopy.
And may I add something?
I have many questions on coagulopathy, vessel sealing devices. And the panelists got any opinion about which one's better than others or which one's safer than others?
I don't know.
I don't think that you have an answer for that. The recommendations is to use the lowest energy as possible in the devices. That is that we are trying to accomplish, to use the minimum energy during the surgery. Now, which device is better than the other? I think that no one can tell you that. I don't think that I personally don't have an answer, and I know that at my institution, probably they are not going to have the answer either.
Especially with coagulopathy. I mean, if you have a coagulopathic patient, that's tough to deal with regardless, even if you have the best energy device.
Another question, is negative pressure theater important in COVID-19?
Now, as far as the guidelines are concerned, it is the best practice. If you have a adequate ventilation of 120 liters per second that can clear the virus droplets from within, and you disinfect, that's the minimum requirement per guidelines.
Okay. Another question is, we know that in COVID-19, they are also more at risk of clots. So the question is it recommended to indicate heparin after a COVID patient who's underwent surgery?
You know, from a guideline standpoint, nothing is addressed. I think, you know, with if you have a septic patient and it's an increased risk for, you know, more coagulopathy or even venous thromboembolic events, I think the standard that we all follow using risk assessment for VTE and applying those should be followed. So if your patient requires per those guidelines, you know, chemoprophylaxis, you should do that. Either low molecular weight heparin or unfractionated heparin, depending on what you use.
You know, many COVID-19 patients right now, they are old and critical patients back in the ICU, and they are getting bed sores and they need debridements. In my hospital, this situation, I can see that. And according to what Ahmed said, I think that if the patient's clinic, the patient's basement urges you to use these heparin and other VTE prophylaxis, you have to do that. It's according to the guidelines.
Okay. I've got a very specific question here. A patient with COVID-19 and is on mechanical ventilation in ICU and is diagnosed with perforated diverticulitis. What kind of surgery would you recommend?
This is a tough question because we have had this before. Unfortunately, when the patient requires mechanical ventilation, is in critical conditions, we have to discuss with the family the chances of this patient having a bad outcome. We try to avoid surgery at all costs, especially if the patient requires mechanical ventilation, because we know the mortality is very, very high. We don't have a specific number, but if you have a perforated viscous, we discuss with the family that probably we won't do the surgery because we know that the outcomes are not going to be positive for this patient. So in this situation, I will. Were you going to say something, Ahmed?
Recently during this, crisis, I've had a emergency mesenteric ischemia. It was an embolic to an 87-year-old. And, sometimes these are tough discussions that you have to have. Those patients probably within these circumstances, would not be able to survive. And the easiest and least invasive way is not to do anything for those patients. But it's a tough discussion to have.
I think that sometimes the patients are too ill to even be transported to the operating room. We have had a couple of patients that unfortunately we couldn't do much because they were on ventilatory support and high doses of pressor. So clearly we knew that these patients were not going to do well regardless if we were going to do surgery or not. So
sometimes you have no choice to do operation because the patients have frank peritonitis. That's the most, the least,
That's why I think that now with this new problem, I think that we need to have a new consent. Besides the regular surgical consent, we have to have this new consent of COVID for these patients because we know that things are changing, and this is a new time, a new type of surgery, that not type of surgery, but a new factor that we have to add into consideration, especially in a sick patient in the intensive care unit.
Definitely agree.
We had one patient, and I'm going to tell you a personal experience because I discussed this with another friend, and he told me that he had the same situation. So this was a 50-year-old guy who they consulted us for pneumoperitoneum on an intubated patient, and there were concerns for perforated viscous. And important is that make sure that you get all the right studies, because once we got this patient had an abdominal X-ray and a chest X-ray for the pneumonia evaluation, and they noticed that there was air under the diaphragm. What happened is, like, this patient had barotrauma from the PEEP pressure from the vent. So that's why he was having pneumoperitoneum. So make sure that you get all your right diagnostic tools before you operate on these patients, even considering operating. We got the CAT scan of the chest, CAT scan of the abdomen, and clearly there was a little pneumothorax, and there was viable small bowel. There was no extravasation of contrast, and the patient ended up dying, but it was not because related of any perforation. It was because of the barotrauma of the mechanical support.
Another question that's come up fairly frequently is the use of treatment of anti-malarials, anti-TBs, antivirals. What's the panel's experience on using all of these medications?
I prefer not to make much comments about that, because in the US things change every hour. New protocols, new medications, don't use this, use this. So I prefer not to make any comments on this, because I don't want to give
I would refer to the NIH guidelines and look at them. They go into details about the efficacy of every drug therapy. However, the NIH does not recommend any modality or any drug currently that would help treatment.
I guess some units do as a cocktail of those anti-COVID-19, whatever you want to call it. I wonder if anyone had any strong feelings about any one of them.
Saeed, maybe you have some experience from your review.
From my review, from the, you mean the drugs we use there?
Mm-hmm.
What do you use in your hospital?
All the patients were treated with hydroxychloroquine, all of them. One patient had hemoperfusion. It was an off-label use of him, you know, to remove the toxins, you know. It was a hot topic 4 or 5 weeks ago, but right now I don't know. One patient, 2 patients with Caletra. It's a combined drug for antiretroviral treatment. And I guess one patient was treated with anti-interleukin 6. So all of them received hydroxychloroquine, and some received other off-label drugs. The most interesting thing was that all of them survived. This was against our previous work that we had 4 patients, that 3 of them died after non-bariatric surgery, and they had COVID-19 infection, and they died, 3 or 4. But all of these survived, so that was the most interesting point.
Okay, let's see. There's a question about bladeless trocars. Has anyone got any opinion on that?
Yeah, I think that those are the ones that we use. I mean, very, very rare. You know, I don't think that rare, but many institutions in the United States, we do not use reusable instrumentation. We use disposable, and we prefer to use bladeless trocars versus a bladed trocar. That is our guidelines at my hospital. Bladeless trocars.
And if you review the comparison literature on bladeless versus bladed, bladed carry more pain, carry more complications, especially internal hernias or incisional hernias. And if you're planning to use bladed, you should close all those trocars, especially above 5 millimeters.
About using trocars, I guess that we have to put aside all, usable trocars. We have to use single-use trocars in this time. Yeah. That's the best option.
Reusable. Disposable, I'm sorry. Yeah.
Another question, it says, should we encourage bariatric surgeons to keep a portion of their practice in general surgery? Because COVID-19 has paralyzed multiple bariatric surgical services around the country and severely impacted the income of many bariatric surgeons. Keeping options open, I guess. Anyone got any strong?
I think that we are, in this time, as I was mentioning to you guys before, we are, doing things that we were not signed for to do. Going to the ICUs, taking care of patients in the emergency room wards. So I think that as a bariatric surgeon, you should also, have to work as a general surgeon and do what you were trained to do. Because we are bariatric surgeons doesn't mean that we cannot practice general surgery. I think that is just something that doesn't make sense. You have to do what you have to do, but I think that you were trained to be a general surgeon, so no doubt that you should go back to your roots of general surgery if you have to.
And for many countries, they are seeing the deceleration phase of this pandemic. So a number of questions have come up. When do you think is the best time to return to elective surgery? How many cases or no cases of COVID-19?
So if you look at, what we all know, and if you combine that, everything that has been presented, so you have to make sure that you're past your deceleration curve. This is the Chinese experience and what Dr. Zheng presented in the first webinar. So he recommended 2 weeks after your deceleration curve ends and your cases flatten. This is when you should start. And this is when you should, before that, you should start preparing. And the list that the American College of Surgeons went through is very comprehensive. And one of the changes that you should have in mind is also if you converted your operating rooms, or if you operate in a negative pressure room, and now you need to stop negative pressure and go back to positive pressure rooms, so that all the rooms do not suck everything in from the outside, and with all the other changes that have to be implemented.
Great. Well, I think we're coming to the end of this webinar. It has been most successful. Lots of questions have come in. I thank the attendees for their interest. I thank the panelists and the presenters for their presentations. They've been very good, very experienced, and very, very generous in sharing their experiences. So thank you very much to Diego Camacho, Ahmad Bashir, and Saad Safari. For the attendees, this webinar has been recorded and will be on the Virtual Academy of the Ifso website. Once again, I thank Johnson & Johnson for sponsoring this webinar.
Thank you.
And we will meet again in probably, I think it's in a couple of weeks, Ahmad, for our next webinar. I think it's a couple of weeks, or maybe next week. I can't remember, but
Yes.
Keep posted on our Ifso website, and we'll have another webinar in the near future. So thank you, everyone. Keep safe.
Thank you. Stay safe.
And stay safe.
Thank you. Thank you. Stay safe all.
And see you in the next webinar. Bye for now.
Bye.
Bye.